Thank you, Anthony, and thanks to all the previous speakers. Our next session, session 4, is going to highlight some of the latest Australian ocular melanoma research. I don't know if I see our first speaker, Svetlana. Svetlana, are you there? Our first speaker is Associate Professor Svetlana Cherepanoff. Svetlana is an ophthalmic pathologist at St Vincent's Hospital, Sydney, and she is the Shirley and John Sarks Professor at the University of Notre Dame in Australia. Svetlana pioneered the benchmark-setting pathology workflow for uveal melanoma, integrating diagnostic and molecular prognostic testing with innovative tumour banking. She also chairs the Ocular Oncology Multidisciplinary Team Meeting in New South Wales, supporting best practice clinical decision for uveal melanoma patients. The title of Svetlana's talk is Navigating the Latest in Uveal Melanoma Testing, Options, Interpretation and Access Pathways. So welcome, Svetlana.
Thank you so much for that kind introduction, Tim. So is my screen being shared?
It is.
Great. I'll just start. Okay, so just a little briefly, I'm a pathologist, so we're doctors and we're specialised in diagnosing diseases in tissue, and I work at St Vincent's in Sydney, and I lead the eye pathology service there. I'm also the lead for the ophthalmic pathology translational research program. I have no financial disclosures or conflicts of interest. So when we talk about ocular melanoma, there's actually 3 different diseases. The first can affect eyelid skin. So that's a cutaneous skin melanoma that you would get anywhere else in the body. The next is the one that affects the conjunctiva. That's a mucosal melanoma. And the other one is the one that affects the uvea. So that's a uveal melanoma. So if you ever get confusing information when you search ocular melanoma, that's because there's 3 different diseases. Oops. So each of them affect different tissues. They're diagnosed differently. They have a different prognosis. They're treated differently, and they have different molecular pathology. So today we're just going to talk about uveal melanoma because that's the one where about half of the tumours have a poor prognosis and a high risk of metastasis. And as you heard from the other speakers, at the moment there's no cure for metastasis, but very encouragingly, there's more and more trials, clinical trials. So what is the uvea? If you follow this purple layer, this is where it sits inside the eye. And in the back, it's called the choroid. Here it's called the ciliary body. And in the front, it's the iris. It's the coloured part of your eye. And it's a vascularized stroma. So it supplies blood to various regions of the eye. And there are resident pigmented cells called melanocytes. So this is what the iris stroma looks like. And this is what the choroid looks like. And these melanocytes are the same as the melanocytes. They come from the same place, the neural crest, during development, as the ones that end up on the skin or the conjunctiva, but they never made it to the surface. And this is the cell that it's the origin of nevi. So just like moles on the skin, you could get moles in the uvea or uveal melanoma. So how do we diagnose it? You've probably heard there's a fundus exam. Optometrists are great at picking up nevi, and about a quarter of Caucasians or more will have them. But there are specific features that an optometrist and an ocular oncologist, which is an ophthalmologist, can look at and say, well, this is actually now suspicious. It's becoming a melanoma. And they can do an ultrasound type test called a B scan, and they can look at it. This is one in the choroid. And we also can do it in the pathology lab to confirm that diagnosis. So we look at it in terms of its appearance under the microscope. So how do we predict the ones that will do badly, the ones that will metastasize? So the clinical testing prognosis is we use AJCC staging. So in the choroid, it's how big is the base and how thick it is. Here's the ciliary body one similarly. And in the iris, it's the number of clock hours of the iris that's involved. So the bigger and the thicker, the worse the prognosis. The more clock hours involvement in iris, the worse the prognosis. And in the laboratory, when we get the eye, here is an eye opened, and this is the uveal melanoma. When we put it on a slide, this is what it looks like. Here's a higher power view, and we can look at a number of, data points, some features. So we can look at, well, does it have these vascular lakes? That's a poorer prognostic feature. Does it have this funny matrix pattern that forms loops? That's a poorer prognostic feature. What type of cell it is? If it's epithelioid, it's a poorer feature. And we can do some immunohistochemistry. This one's showing that these are melanocytes. That's a MART antibody. And this one's looking at whether BAP1 is expressed in the nucleus. So for an enucleation in our lab, we'd like to collect as many data points as possible, and we collect about 35. So we've got some clinical, data points to collect. We've got lots in the pathology lab as well, and we try to put them together to predict how well or how badly somebody's tumor is going to do. But now we're in the era of personalized or precision medicine, which is really molecular medicine. So not only are we looking at how big it is, what structures is involving, and what the cells look like, we're trying to work out what's the programming inside the cells. So if you look at all human cells, and especially tumor cells, we can have changes in tumor cells at the level of the chromosome, at the level of the DNA or the gene, at the level of the RNA. So the DNA is your blueprint and the RNA are instructions to make protein. So I'm going to talk you through all the different changes at these levels that we now know. So this is a really groundbreaking study. It was part of the Cancer Genome Atlas project, which is an international consortium that sequenced all the common tumors. And there was a lot of advocacy to add uveal melanoma to this program. And the results were published in 2017. So it looks like you can actually predict metastatic risk, and you can define 4 groups. So they're up here. It's 1 to 4 here. Sometimes you'll hear it as A, B, C, D. So it's the same thing. This is a very complex diagram. I'll talk you through it. It's a summary of the findings. So here are all the changes at the level of the chromosome. And this is chromosome 1 all the way to 22. And this is sex chromosomes. And if you divide each of these rows, the top is the short arm of the chromosome and the bottom is the long arm. And each of these columns is a patient. So 80 enucleated melanomas were included. We have what happened to the patient in terms of prognosis here. And then we have some RNA changes and some DNA or gene level mutations. And we'll go through that one by one. So at the level of the chromosome, uveal melanomas, the worst prognosis melanomas tend to lose the whole of chromosome 3. So this is chromosome 3. These are the worst prognosis groups. And you can see both the short arm at the top and the long arm are blue, which is lost. They also tend to gain copies of the long arm of chromosome 8. So there's chromosome 8. And if you look across here, hardly any gains in the group 1, starting to get some in group 2, and many, many copies in groups 3 and 4. This has got the highest copies. So you can actually get quite good TCGA 4 group classification just using the data on chromosomes 3 and 8 alone. If you can assay the whole of both chromosomes and calculate the number of copies in the long arm of 8, how many gains you have. So how do you do this in the lab? Well, we've always had, this is called metaphase cytogenetics. So if you can send fresh tumor to a cytogenetics lab, they'll grow the tumor cells, they'll make them go into metaphase, and they'll stain the chromosomes and then manually line them up. And by the size, shape, and the banding of the staining, you can arrange them from chromosomes 1 to 22 and the sex chromosomes. And you can see instead of 2 copies of chromosome 3, we've only got 1. And we've got gain of the long arm of chromosome 8. So that's 8q gain. So this would be a group 3 by TCGA. So it's good enough So that's all you had. But you do need fresh tumor and you do need a cytogenetics lab. It's a bit fiddly. It can fail because tumor doesn't grow. The next one, which could be potentially helpful if a laboratory does this, is called fluorescence in situ hybridization. So here we're not looking at the whole chromosome. So for chromosome 3, we're just looking at one small region in the short arm that encodes BAP. And we've got part of the sequence of BAP, the complementary sequence, and we see if it hybridizes, if it sticks. It's like Velcro, you know, the positive and the negative side. If it sticks, it'll give us a signal. And we can see where the chromosomes are by trying to make the centromere fluoresce. So in this diagram, each blue blob is a nucleus of a tumor cell, and each green dot is showing you that's where the chromosome is, and every red dot is where BAP1 is, a short arm of chromosome 3, or a very small part of it. So if you look at each cell, you expect to have 2 copies of the chromosome 3, and you expect 2 BAP. And you can see this nucleus has only got 1 of each. This nucleus has only got 1 of each. This nucleus has got 1 of each. So that is a loss of at least that small region of the BAP1 gene on chromosome 3. And this is interpreted as monosomy, or loss of chromosome 3. It's quite fiddly and you need a fluorescence microscope, and there are lots of things that can go wrong with this test. But if this is an archived piece of tissue that was done maybe, I don't know, 2-3 years ago, and it's sitting in a paraffin block, you can still do this test. Similarly, you can look at a part of the long arm of chromosome 8 where the MYC gene sits, and it gives us, you see here, there's multiple copies of 8 and lots of dots of the red in each of these nuclei. So we've got gain of that part of 8q. So there are lots of, you know, it's not as refined, this test, as you want it to be, but it's actually not a bad surrogate. The best way to look at it is to do a chromosome microarray. So you can actually hybridize to multiple little regions on every single chromosome. And there's 850 such 50,000 such regions in the test that we use. And we collaborate with our cytogenetic scientists at the Kids Hospital Westmead for this test. And you can see you get this molecular karyogram. So based on all these little dots of hybridization, you can tell which parts of which chromosome are missing or multiplied. And this gives you very, very nuanced data. And this is what we like to do. At the level of the gene, there are also abnormalities. So you can see, as Matt alluded to, pretty much all of the
You've
cases.
got 1 minute, Svetlana.
Oh, okay, I'm sorry. So this is the level of DNA. We can actually do sequencing. And these tell you that it's uveal, and these are prognostic genes. And what we use in the nucleations is the TSO500, which gives you 500 gene information on 500 cancer-associated genes, as well as tumor mutational burden and MSI testing. So at the level of RNA, you've probably heard of the Castle Biosciences test. It only looks at 15 mRNA transcripts, and it's quite expensive to access. It's a US company. At the protein level, BAP1 is the one that we use. TCGA looked at the mRNA of BAP1, not the protein, but it's a good surrogate. And if you had nothing else in the lab, you can always do BAP1 immunohistochemistry. So up here, tumor cells have brown nuclei, BAP1's in there. Here, they're not. So that's a poorer prognosis. If nothing else, you can always do this, and you can get good or bad. This is our workflow for enucleations, and we've developed a workflow for our fine needle aspirate biopsies. And we have a specific way of asking surgeons to submit this. And this is our actual workflow that we work off in the lab. So just how do you access this? Well, in our laboratory, all of this is no out-of-pocket costs. So histology, immunohistochemistry, and the microarray. The sequencing is currently being funded by my grant, which is about to run out, but it's between $650 and $1,800. There's no Medicare item number for sequencing. And a note about testing, you've got to be careful that there's clinical grade testing and research testing. So in the clinical setting, it's what the doctors will use to make decisions. In the research setting, it's just about finding out, new pathways, maybe new therapeutic targets. So it can't be used to make decisions. I work across a huge number of a big multidisciplinary team, and the grey people are the Sydney people, the people in black are the Melbourne people. Privileged to have such great working relationships with everyone, and it's been a really growth journey for me over the last 10 years. I want to thank Anthony and the Melanoma and Skin Cancer Trials people and AOMA for giving me the opportunity to speak. Thank you.
Thank you, Svetlana. If you have any questions for Svetlana, we'll take a Q&A at the end of the session. So our next speaker is Dr. Aaron Beasley. I've been working with Aaron here in Perth for a few years now. Aaron is an early career postdoctoral researcher in the School of Medical and Health Sciences and the Centre for Precision Health at Edith Cowan University in Perth. His research has focused on liquid biopsies in uveal melanoma, with specific focus on circulating tumour cells and circulating tumour DNA. The title of his talk is Circulating Tumour DNA as a Biomarker in Uveal Melanoma. Welcome, Aaron.
Thanks, Tim. Can you hear me? Okay.
I can.
Great. Yeah, so today I'm going to talk about circulating tumour DNA in uveal melanoma. Thank you to Richard and Anthony for also talking about it, because I think it's a really great biomarker and I think that we should work towards implementing it clinically. So circulating tumour DNA, as the name suggests, is essentially tumour fragments that are DNA, and they circulate around in a fluid. Usually when people are talking about this biomarker, it's from blood, but realistically it can be in any fluid within the body, and this includes your humours within the eye, so the vitreous and the aqueous. And when people talk about liquid biopsy, usually they're referring to circulating tumour DNA from the blood. And the reason for this is it's such a great molecule. It tells you a lot about the tumour, and it's very easy to work with. It's very easy to extract. It's very easy to test for, and you can get a lot of genetic information from this because you can. It's genetic material from the tumor, so you can see mutations, you can see chromosomal rearrangement, you can see copy number alterations, and you can even look at more fancy things like gene expression if the frequency abundance is high enough. So it's a really great biomarker. And Svetlana showed this figure before. This is from the TCGA. And uveal melanoma, because it's so unique in terms of having such highly recurrent mutations, either to the gene AQ pathway or the prognostic genes through EFX, SF3B1, and BAP1, you can cover with a very minimal panel that's very cost effective, almost all patients. So you can actually detect ctDNA in almost all patients in a very straightforward manner. So it's uveal melanoma is a perfect candidate for utilizing circulating tumor DNA. So I've kind of broken my presentation up into two parts, primary disease and metastatic disease, because they're a bit clinically different. So starting with the primary disease, back in 2018, we first described ctDNA detection in primary disease, and we found that it wasn't particularly detectable, so about 23%. And this wasn't driven by tumor size either. So there's something going on within the tumors that were detectable. It could be to do with the growth rate or turnover rate within the tumor, but tumor size wasn't a driver of that detection. And subsequent studies from other groups have also kind of confirmed that ctDNA in the primary stage is generally quite low. And so when we followed this up about 5 years later, we wanted to see whether or not detection of ctDNA at that time point, so this is pre-plaque, pre-enucleation, to see if ctDNA could actually provide any prognostic information. We found that the levels at that time point were not predictive of overall or progression-free survival. So at the moment, kind of where the field is kind of moving to, it's very niche, very small field. It's moving to utilizing the fact that most patients will have a radiation treatment. So this is either plaque or stereotactic radiation to treat the primary lesion. And what happens when you treat those lesions with radiation is they actually release more cell-free DNA, or ctDNA, I should say. They release more of that, and then it becomes detectable. And so what you could do, and this is one study we're running, I was hoping to show the results today, but it wasn't quite ready, is you can utilize the fact that those 3 prognostic genes can tell you whether or not the disease is going to spread or not. You could utilize ctDNA at this radiation time point and potentially use have a minimally invasive prognostic test. And oh, I don't know why that skips the end. And so this has kind of been shown in aqueous humor. So as I mentioned, ctDNA isn't just a blood-based biomarker, it's any fluid. And this study actually showed that in a post-radiation sample, if you take aqueous humor, you can actually get the chromosomal copy number alterations that were associated with prognosis. So this is done through a liquid biopsy rather than taking from the tissue. And that's kind of basically the scope of ctDNA research in primary disease. It's very niche, very small, because where ctDNA really shines is in the metastatic state. So as you can see on this graph here, metastatic patients harbor a lot more circulating tumor DNA than their primary counterparts. That makes it more detectable, makes it more informative. And that's because ctDNA is significantly associated with tumor volume. So as you have more tumor, ctDNA increases. If you have less tumor, there's less ctDNA or it's undetectable. And this is across different cohorts, different centers, different studies. Everywhere you look, ctDNA correlated with tumor volume. And then because of this, because ctDNA is so highly associated with tumor volume, it also translates to being predictive of survival. And this is, again, across different treatment. So for example, pembro-itino, tebentafusp, or clinician's choice, which is usually some form of immune checkpoint inhibition. So if you have a high level of ctDNA at baseline, you will do worse than if you have a lower or undetectable amount. And so then you can use this prognostic information. Maybe we've heard about all these wonderful drugs being developed. Maybe you can go on to, for example, in the future, you could say, well, ctDNA is high, you should go to a more aggressive treatment. ctDNA is low, you could maybe have something that's a bit more tolerable. But that's a future study to be done. So not only can ctDNA be used cross-sectionally, but it can actually be used longitudinally. And this is an example from Francis et al. And our team as well. And what we looked at was whether or not ctDNA changes in response to immunotherapy. And you can see that for patients that are undergoing ipi-nivo, which is known not to particularly work very well in uveal melanoma, but you can see that after treatment, or at least the initial treatment of ipi-nivo, there is a 1 to 2 log-fold reduction in the levels of circulating tumor DNA, which is showing that ipi-nivo, at least at this time point, is actually giving some benefit in disrupting the tumor. Unfortunately, it doesn't work for very long and patients do progress, but you can see that there's something going on and you with the tumor, and you can monitor that using circulating tumor DNA. And this is also true for PKC inhibition, and also true not just of baseline. So if you look at ctDNA even early during treatment, you can utilize the changes or the levels of that during treatment, and this is true in the tebentafusp cohort as well. You can look at that and say whether or not someone is going to respond or have long-term benefit. And you can also use ctDNA to see if there's any early relapse. So for example, in this case study that was presented by Park et al., you could see ctDNA rising while the radiological scans were saying stable disease, showing that because this is correlated with tumor volume again, you can see that that patient is going to have relapse before radiological progression. And potentially, again, these are future questions and future studies to be asked, but can you swap treatments when ctDNA rises to try and get a better survival outcome for patients? And back from our 2018 study, when we were doing the primary assessment, we found that when we were longitudinally monitoring patients for metastases, we could see that in quite a few patients, ctDNA was rising before radiological progression. So on radiological scan, so this is an example of a PET scan, there was no active disease. So this patient was classified as metastatic free, but we saw that ctDNA was rising to detectable levels. And because this is so highly specific to uveal melanoma, we know that there is actually active tumor there. And so this led us to a collaborative study with the team from Erasmus MC, the ROMS team. And we found that ctDNA is detectable in most patients at the time of metastases or beforehand with a very good specificity and positive predictive value. But really importantly, 45% of these patients had ctDNA detectable prior to the clinical, so through radiology, metastases diagnosis with a median lead time of 4.4 months. So that's a really good opportunity to start, treatment earlier again in the future. And this was kind of a confirmation of a previous study by Le Guin, where they showed that 58% of patients had a ctDNA positive test prior to the diagnosis of recurrence with a mean lead time of 5.7 months. And so kind of where ctDNA is currently sitting is it's a really great molecule. So it can be used at different points at the moment. Really, metastatic disease is where it shines, but you can use it to not only look at prognosis at baseline before any treatment, you can use it to longitudinally monitor how well a treatment is doing. And you can also use it to screen for metastatic disease. And I think that at some point it would be good to, alternate. So for example, you have a 6-month radiological scan, and then in between those radiological scans, you could have a ctDNA test, because I think they both have important information to give. And so because some of this data was presented from our lab, I just really wanted to thank patients and volunteers who donate their samples to us, because without them, this is not possible. I also want to thank the Royal Perth Theatre staff, who are amazing. And I wanted to also thank Tim. So Tim said we've been working together a couple of years. It's actually almost 9 years now. So without Tim's help, none of this is possible as well. So that's it for me. Thank you very much.
Thank you, Aaron. Gosh, 9 years goes past quickly, doesn't it?
It goes very fast.
I did think it was more than 2. So if you have any questions for Aaron, we'll leave that to the Q&A at the end. And so I'd like to move on. We're slightly ahead of time now. Thank you, Aaron. And to Dr. Jenny Liu. Now, Jenny is a medical oncology staff specialist, and she's the translational lead of the early phase unit at the Kinghorn Cancer Centre, that's at St Vincent's Hospital in Sydney. Jenny specialises in head and neck and non-melanoma skin cancers, and she has active research interests in supportive care, including the development of novel interventions to address fear of cancer recurrence in cancer survivors. And her talk is entitled Fear of Cancer Recurrence, Addressing the Elephant in the Room. Thank you, Jenny.
Thanks so much, Tim. Can you all hear me?
We can.
See my slide? Okay, excellent. So as Tim has mentioned, I'll be talking about fear of cancer recurrence in uveal melanoma. This slide shows my disclosures more related to my work in early phase drug development, but I guess the key thing I wanted to disclose is I'm actually not a uveal melanoma researcher, but my research and interest in fear of cancer recurrence hopefully is a very relevant topic. I've structured my talk to address both consumers and patients in this webinar, as well as clinicians. And beginning with the end, wanted to highlight the 3 key takeaways from a patient perspective. When you are facing cancer, worry about cancer getting worse or returning is very common and very normal. As Melody mentioned earlier, this is a high unmet need, and addressing this worry with your family and caregivers, but also your healthcare team, is really important. And if your worry is getting to a point where it's consuming your life, affecting your ability to plan for the future, there is professional help available. For clinicians and researchers, fear of cancer recurrence is a prevalent and highly unmet need, especially in rare cancers like uveal melanoma, and with the advent of trials and better technologies such as ctDNA, we also need to be addressing these unmet needs in our research. Increasingly in other cancer types, there's increasing evidence for stepped care interventions to address FCR. And I would encourage those doing research to implement instruments that are now validated for measuring FCR and fear of progression as part of your trials. So with the cancer diagnosis and treatment comes side effects, financial toxicity, uncertainties about the future and planning for family, and obviously mortality. And all of these factors contribute to worry. However, worry for cancer recurrence is very common. 60% of patients surveyed report moderate levels of worry and 20% severe levels of worry. And in fact, degree of worry isn't always correlated with the actual objective risk of recurrence. Often there are many triggers for worry, and these might include the need to have scans, anniversaries at the time of cancer diagnosis, news and other events, and as well as family and friends who are maybe affected by cancer. And this worry manifests often as intrusive thoughts affecting ability to live after diagnosis, hypervigilance, but also worry before and after scans, such as scanxiety, and can be associated with significant levels of distress, anxiety, and depression. Why is it the elephant in the room? And this is because as doctors and health professionals, we are taught very well about how to monitor for recurrence, to discuss results of scans, to discuss side effects, but we're not as well trained in how to deal with and discuss psychological concerns with patients. And sometimes restrictions in terms of time and availability during clinic can make this quite challenging. When I sought to understand this better in my research 5 years ago, we conducted a systematic review to identify whether there was any validated instruments and strategies to address worry, and found really nurse-led interventions, but no doctor-led interventions. But recurrently, surveys by patients reported that patients sometimes feel uncomfortable raising FCR with their doctor and wanting more prognostic information and information about risk of recurrence, and many health professionals reporting difficulties in addressing this worry. It's relevant, I guess, in uveal melanoma, especially in those with a higher risk of recurrence with BAP1 loss, but also the fact that sometimes, despite the ongoing trials, there currently are not effective therapies to reduce the risk of recurrence. And intensive scans of patients with advanced uveal melanoma can lead to scanxiety. There have been some research conducted out of Professor Brown's group in the UK, and this large study of 708 patients looked at the relationship between demographics, symptoms like ocular irritation, functional problems, and FCR on an abbreviated 3-item Likert scale, and found that FCR trended to reduce in severity over time but did not disappear, and functional problems and symptoms such as visual alteration predicted levels of worry. In terms of FCR and prognosis, there was an interesting trend that those with poorer prognosis did have high levels of FCR, which did abate over time, but there was more likely for those with FCR and poor prognosis to have higher levels of anxiety and depression, highlighting the need for more intensive psychological follow-up. For those with advanced cancer, it can be universal to have worry if the cancer can't be removed, eliminated, and cured. And sometimes, as cancer can be a chronic illness, especially for those who do well on treatments like tebentafast, addressing the ongoing worry and the need for ongoing monitoring is important. And so sometimes the phrase I like to use in my patients is to prepare for the worst, but to hope for the best, and accept that uncertainty is a common part of the cancer journey. Eng and colleagues have looked at patient perspectives on quality of life in metastatic uveal melanoma, and in a semi-structured interview study, they looked at, they used FACT-ICM to capture immunotherapy-related toxicities, but identified that the emotional unmet needs exceeded that of physical symptoms, with themes such as fear of progressions, scanxiety, uncertainty, and time toxicity coming up and again. And so there are validated instruments now that are developed, and hopefully with ongoing trials, these such as FOP short form can be used to objectively measure and monitor the impacts of treatment and trials on levels of worry in participants. Through my work and largely through early stage breast cancer patients, we came up with a 5-step clinician intervention. And this is a simple educational technique which we have used to train health professionals on how to discuss worry with patients. And the premise is summarized on this slide. Essentially, talking patients through the fact that worry about recurrence is normal, providing patients information about their risk of recurrence should they want to get this information, and also some simple strategies on how to manage worry. Symptoms that they should worry about and should escalate to the healthcare team for earlier surveillance or follow-up should be discussed. And if, despite this brief counselling, patients are still very bothered, offering psycho-oncology referral. We developed this 2-page handout to give to patients, and then conducted a pilot study across 2 hospitals to identify whether in women with early stage breast cancer, that routine use of the Cypher intervention reduced levels of worry in patients. Overall, the intervention took 8 minutes to deliver and was very highly acceptable and highly recommended to others. And we found that levels of worry decreased significantly and was maintained 3 months after the intervention. In order to see whether Cypher could be routinely implemented into practice, last year we conducted an Australia-wide study recruiting health professionals, medical radiation surgical oncologists who see women with early stage breast cancer, and trained them on the Cypher intervention online, and then surveyed them after training to see if they implemented it into routine practice. So in summary, these were the participants that we recruited into this study. A mean age 41, majority of participants were female, medical oncologists, and largely working out of urban practices. And at baseline, most reported some difficulty managing FCR, but all expressed interest in FCR training. This is what the online module looks like. And we found pleasingly that self-efficacy increased significantly on all the domains after this brief training that took 30 minutes. And adoption rate was 82%. So the vast majority of participants actually utilized Cypher in their routine practice on average 4 times over the 3-month period. So there's a lot of ongoing work now to embed FCR screening and step care intervention into routine oncology practice. And this is a diagram put together by Professor Ben Smith, a psycho-oncology researcher who I work with, and ideally utilizing FCR interventions that are tailored to the severity of worry for patients. So those with mild levels of worry are offered self-help online material or brief discussions with their clinicians, but those with more moderate to severe levels of worry are offered specialist care and then are monitored. We are also actively expanding our research to include patients with advanced cancer and adapt the Cypher intervention to help all professionals, not just doctors. So the importance of clinicians addressing Cypher is that it really helps to improve patient-provider rapport and communication. And we'll be surprised because when we discuss prognosis, the people who worry the most actually are most likely to over or underestimate their risk of recurrence. Early identification of worry is also important from a health service utilization perspective because it can reduce the need for unnecessary scans or blood tests. And for patients, a guide to managing FCR, talking about it with your family, your caregiver, prompting this with your healthcare team, and utilizing it as a motivator to engage in healthy lifestyle behaviors such as eating well, exercise, and attending surveillance and follow-up appointments. There are many strategies to manage worry, and we encourage you to see psychologists or consider medication if your worry is severe. So just bringing up those key takeaways again. And wanted to leave some useful resources. There's a lot of information online. Some of this will be quite broad, others for specific cancer groups. And the Cypher training is actually still online and available if there are any health professionals that are interested in accessing this training. And I'd like to acknowledge the research team and funding from the Sydney Breast Cancer Foundation and Sydney Local Health District, which kicked off this work. Thank you.
Oh, thank you, Jenny. That was fantastic. I think it's part of our practice that is often poorly done, and certainly I'm I think guilty of failing to manage this fear of cancer recurrence as well as I could. So perhaps I need some FCR training myself, and those 5 steps of clinician intervention were really helpful. Prepare for the worst and hope for the best. It's a pretty good philosophy for life, I think, as well. Now, our circulating tumor DNA test. So is that a long way off? I know we just use it as a research tool at the moment. Do you foresee that being more widely available?
So at the moment, yeah, as you said, it's more of a research based question in Australia. You can send samples off to companies like Foundation One, Guardant, Natera to do testing, but it is out of pocket and is quite costly. They're not cheap tests if you pay a company to do it. So it would be good to get enough clinical evidence that it could be reimbursed through MBS or something like that in the future. But at the moment, in Australia at least, it's not a covered item.
Sure, thank you. There was a question for Jenny, if she's there. Do you find increased FCR in patients treated in a more central oncology department compared to those that have more shared plan between larger metropolitan centres and smaller local hospital centres? So is there much difference metropolitan versus country in their outcomes?
Yes, that's a really interesting question, and I don't think has been very well studied, certainly not for rare cancers like uveal melanoma. When we look at systematic reviews on factors that predict higher levels of worry, it tends to be demographic features, including younger patients having higher levels of worry, sometimes younger women, perhaps with young families, and worry about that impacting on their, mortality. In terms of regional versus rural, factors that also come into play include level of isolation and support. So patients from disadvantaged socioeconomic situations and also more isolated patients tend to have higher levels of worry. We find also when patients transition, so from that intense treatment and monitoring period back to surveillance with less frequent follow-up, the level of worry can increase as well. But I think certainly this is worth further research.
Thank you. Well, I'm not seeing any more questions popping up, so I'd like to thank all of the speakers for this session.
Tim, am I able...
if someone else had a...
Yeah, so there was a question that was in the chat, and it was about BAT1, and I think it goes together with Aaron's, discussion. So in terms of circulating tumor cells, at the moment, it's great for looking at residual tumor burden, and the tests that are available tend to be for the more common cancers. So if you wanted to look for BAT1 in circulating tumor cells, that's probably not so great for this cancer. And most of what's available is quite expensive out of pocket. Even going back further, we can't even sequence the primary tumor on Medicare. So there needs to be a lot of advocacy from this community to get this cancer into the schedule. So we don't have that. And the glioma people and the sarcoma people, who all rare cancers, manage to do that for Medicare. So right now we can't even sequence the primary, and if we don't sequence the primary, doing the tumor circulating tumor cells is going to be problematic because it's based on the signature of the primary.
So what we need to do is to recruit Melody from the US to come over and advocate for us. Is that what you're saying? Maybe, or we should all advocate more than we.
As a community, we can all do that, and we certainly have some very motivated and committed patients, and we've got support from the MAS people. So
yes,
we definitely need to do that for uveal melanoma patients.
And nearly 400 registrants today, so we're doing our best, I think. So thank you very much to the 4 speakers for this session. I will just remind people that donations can be made to ocular melanoma research. We're very grateful for all donations. You can donate via the Ocular Melanoma Research webpage. The link's in the chat box. And as Anthony's already mentioned, any donations over $2 are tax deductible, and we're only a short distance from the end of the tax year, so you can make a tax deductible donation to melanoma research. So we're going to close this session, and that's the end of the morning. We're going to reconvene after lunch. So the next session starts at 2 p.m. Australian Eastern Standard Time. So thank you for all your participation.